Dr. Aruna, you can come on video and Dr. Arunalata, you can come on video and say some few words, then I will just start the presentation. Dr. Arunalata, you are... Dr. Arunalata? Dr. Arunalata? Am I audible?
Yeah, you are audible. Padma, I think you have to start the YouTube.
I have done that. I have done that now.
Varliye.
Live on YouTube.
அப்படியா எனக்கு வரலையே யூடியூப்ல சரி நான் திருப்பி பாக்குறேன் ஓகே
one second let me see. Hello? Yeah, it's audible here, but you are not audible in the either. One second, hello. Give me a minute. I'll just, I'm just streaming the event on YouTube. Just give me a minute.
வருது இப்போ யூடியூப்ல வருது
Okay, fine. Okay, Dr. Aruna, you can start. Dr. Arunalata? You are not audible. You are not audible. You are over the phone. You are audible, but not in the screen. Yeah.
Padma ma'am, are we going to have a break after the initial presentation?
Dr. Arunalata?
Padma ma'am,
Yeah.
after the presentation, are we going to have a break?
No need, Karthik. We can continue.
We can continue.
There is no
Okay,
need,
that's-
no need for break.
Speaker full volume வைக்கணுமா?
Dr. Aruna, you are audible. You can talk. Dr. Aruna, you are audible. No, you are not audible.
Welcome to Dr. Karthik.
I think you are on 2 devices. Now, I think you are on 2 devices. There is some issue, I think, Dr. Aruna. Am I audible? Yeah. Greetings from Tamil Nadu Pondicherry chapter of IAPM. So we welcome all of you for this guest lecture cum slide seminar session by Dr. Karthik Kalyanasundaram. He's so this is the year-end session, and the session is going to be on renal tumors. And Dr. Karthik Kalyanasundaram graduated from Madurai Medical College, and then he did his post-graduation in Keel Park Medical College. Then went abroad to UK, and he did his FRC path. He's a consultant histopathologist in Stoke-on-Trent University Hospital of North Midlands. And his fields of interest being GI pathology, uropathology, non-gynec cytology, and non-forensic postmortem. Then he has UG teaching at Keel University and teaches postgraduate histopathology trainees also. So over to you, Dr. Karthik. I think Dr. Aruna is unable to come on live or something. Aruna, are you able to talk? Otherwise, Dr. Karthik will. So we welcome you all. It's a great privilege to have Dr. Karthik for this session. This being the year-end session of Tamil Nadu Pondicherry chapter of IAPM.
Yeah.
You can start sharing your
yeah,
screen.
Sure. Yeah. Thank you for inviting me. It's been it's a privilege to speak to all of you, and I can see many of my professors are there in the list. I saw Hema Madam and A.V. Shanti Madam and Tilagavati Madam also was there in the participants. So I'm actually basically pitching this talk for mainly for postgraduate trainees. I think many of the facts what I'm going to say will be already known to all of you. It is just to reinforce the important aspects in dealing with renal cancers, and I'm going to deal with only with common type of renal cancers. So the plan for today's talk is initially I'm just going to go through a PowerPoint on how to handle renal nephrectomy specimens for renal cancers, and then And then we'll go through the slides, eight cases which I put it in the web for the as a slide seminar. Um, this is more practically oriented. I'm not again. I'm not going more into theoretical basis. Just practical with whatever I have learned. I want to share with you. Um, One more thing. Were you able to view the images properly, or was there any difficulties?
Yeah, everybody were able to view the images. That was not an issue.
Okay. Okay. Thank you.
I think you have to go to the slideshow mode, I think.
Yeah, I'm going to do that one.
Yeah.
Are you able to see the PowerPoint now?
Yeah.
Okay. So the renal tumors. I mean, since my one of the specialities is uropathology, so I come across quite a lot of renal tumors, and it is on the increase. We see quite a lot of cases, and with the new WHO, and also there are a lot of new entities in the renal tumors. One of the important aspect of the renal tumors is many of them could be diagnosed with morphology, um, and immunos are helpful in when we got any difficulties. And also each of the renal tumors have a molecular genetic event as well. So there is a good correlation between genetic or molecular aspects and morphological appearances. So and they have got a very distinctive morphological appearances as well. So I'm just going to bring some of the common renal tumors which you come across in daily routine practice, so that you can you can use this information to in your daily practice. So, this PowerPoint is mainly again it aim for postgraduates to deal with if you come across refractomy specimens, what are all the important aspects, what are all the prognostic factors which we should be looking for from in grossing and also on microscopy. Um, so as you know from the TNM staging, the size of the tumor is very, very important. Um, so we have to measure to the nearest millimeter so that we can give an accurate staging. So size of the tumor is very, very important. Next is and we have to, and the tumor which are very close to the renal hilum or I'm going to show some of the pictures now. So those are the ones we need to be very examine it very carefully, which I will come on to the next slides. As you know, many of the renal cancers, they have a propensity to um, to metastasize through renal vein, and renal vein resection margin is shown to be a very important prognostic factor, and that because of the increased risk of metastasis or involvement of the IVC. So taking the renal resection margin before even sampling the tumor is very, very important, or also to prevent any contamination of tumor. When I get the refractive specimen, the first thing I do is to take the renal vein resection margin, so that you can prevent carryover and all sort of things. Again, one of the macroscopically, we need to identify if there is involvement of renal vein or its tributaries. Even a small renal vein involvement, tributaries is significant, and it will be staged as T3, PT3 stage straight away. In the TNM8, now involvement of the pelvic calyceal system is included, which again sometimes when we talk about renal cell carcinomas, they can invade into the pelvic calyceal system. Again, they will be staged as PT3. Many of these nephrectomies, which is done nowadays through laparoscopy or robotics, they don't take the adrenal glands to preserve the function of the adrenal glands. But if there is any radiologically any concern that there is adrenal gland involvement, then adrenal gland is also taken, and then we have to assess whether there's a direct invasion or if you think it's a drop metastasis with normal intervening kidney tissue. So that is something we need to assess on the macroscopic images, macroscopic when you're dealing with the specimen. And then the lymph nodes. Of course, there are lymph nodes around in the renal hilum, around the renal blood vessels, and normally you won't see them, but if then they are involved, you can see them. It's prominent, and that again gives you the correct TNM staging, and also so the further further chemotherapy and everything can be planned after the surgery if there is lymph node involvement. Okay, that's the main things about the handling of the macroscopic specimens. So this is so usually when I get the kidney tumor, you bivalve into two halves to see the tumor, and then this is a transverse slices of the two halves to see. This is the renal hilum, where you can see the tumor going into the renal hilum. So if you slice it transversely from upper top end to the bottom, then you will be able to see the renal vein invasion very nicely um, in the region of the renal hilum. This is another example of renal vein invasion where it sliced transversely. You can see the tumor is extending into the main renal vein branch. Now, the other important concept, which is very, I mean, this is sorry, this picture is actually to show renal tumor involvement into the pelvic calyceal system. So you can see that's the brown tumor which is entering into the renal pelvis. This will be staged as PT3. Now, the other important aspect. So when you sample the tumor, so you have to sample 4 or 5 blocks of the tumor. You have to sample areas where you think there is necrosis. Previously we usually tend not to sample the necrotic areas, but one of the independent prognostic factor is coagulative tumor necrosis. And if you think there is necrosis, you will have to take a block to confirm it is necrosis, because the tumors with high nuclear grade and coagulative necrosis, they tend to do the prognosis is poorer when compared to those don't have those two features. So coagulative necrosis, you have to take a block to confirm it histologically, again because of the importance of the prognostic indication. The third, this is the most, it's not recent, it has been there for the last 5 years, renal sinus involvement. So renal sinus is nothing but the fat around the renal pelvis. It acts as like a cushioning effect for the ureters, renal artery, and renal vein. So those so tumor but particularly large tumors, more than 7 centimeters, they tend to involve the renal pelvic fat, and we have to take adequate blocks to identify the renal sinus invasion, because those may not be visible very clearly macroscopically, and they may be present microscopically. So basically you have to look for tumor infiltrating into the renal sinus fat. So if I go back to the picture before, so you can see this is the fat I'm referring to as the renal sinus fat. So you can see that is the upper pole. This is the lower pole. You can see the tumor in the lower pole, and that is the renal hilum where all the ureter, vein, and artery can be seen. And then here you can see a fat around these structures which help to which acts as a cushioning event, and involvement of this fat. So you can see here the tumor macroscopically seems to be very well demarcated from there, but taking a block from there will help to identify whether the tumor is invading into the renal sinus fat, or sometimes you can even see some. So again, when we say renal sinus fat, there are actually, it's not only involvement of the fat. You can also have small capillaries which the tumor may infiltrate into the capillaries, and through the capillaries it travels along the renal vein, and then you can get renal vein metastasis through the renal vein. So that's very important. And in my experience, I've seen lot of tumors upstaged by taking just by taking more 3 blocks of that area. You could upstage a tumor from PT2 or PT1 to PT3 because many of them have this renal sinus invasion. um, yeah. So now next thing is the histological type. So histological type, again, as I mentioned before, they've got very classical macroscopy and microscopy appearance. So many of these tumors, just by macroscopic appearance, you can diagnose them as as a histological type. So this one is the classical appearance of clear cell renal cell carcinoma with this multinodular appearance, and many of these nodules yellowish color, um, and you've got areas of hemorrhage, um, and they tend to push the renal capsule. Um, Not you don't see many of them infiltrating into the perirenal fat. Again, I know it's one of the criteria, but we don't see that quite often. It usually pushes, it forms another pseudo capsule, fibrous capsule around it, and then keep pushing the renal pelvis, renal perirenal fat. So usually a classical clear cell renal cell carcinoma will look like this, with yellow nodules and then areas of hemorrhage. You can see some central areas of necrosis, and then here you can see it is pushing into the one of the branches of the renal vein. You can see the renal pelvis there, which is free. So that is a typical example of clear cell renal cell carcinoma. So this is another example which often they show cystic change. This is in the lower pole. And again, you can see a thick fibrous tumor capsule around it. And that's the renal sinus. It seems, again, it seems to be well clear of the renal sinus, but we need to take some blocks at the interface to check there is microscopic invasion present or not. So this is again clear cell renal cell carcinoma. You can see a sudden change into a very gray white solid looking very firm kind of areas. This is what we have to look for in a clear cell RCC. This is the sarcomatoid change, because again sarcomatoid change have a very poor prognosis. So we need to identify it macroscopically and take a block from the sarcomatoid areas, which yeah, mainly for confirmation of the sarcomatoid change. This is another example. Again, you can see the main tumor there. This is the main tumor is a papillary RCC. You can see it's very granular kind of appearance. They usually be many of the papillary tumors, they undergo infarction, and then you can see here the solid appearing tumor there, and this is sarcomatoid change. So again, sarcomatoid change can be seen in clear cell carcinomas, papillary, and I've seen a couple of cases in chromophobe renal cell carcinomas. So again, so sarcomatoid carcinomas in any of these tumors as a poor prognosis. Yeah. So again, this is again another case with the sarcomatoid. So another case with sarcomatoid transformation, and there is invasion of the renal vein. So this is a typical appearance of a papillary renal cell carcinoma. I'm just showing some macro images so that you can, just by looking at the macroscopic appearance, you can come to a conclusion whether what histological type is. So this is a typical papillary RCC. It's very granular kind of appearance, and then they tend to have a very pale brown appearance, and usually it will be very soft. When you slice it, it will be very soft in appearance. I'm just checking now. Are you able to see all the images? Okay, is everything okay?
Yeah. We are able to see it. No issues.
Thank you. Thanks. Yeah. So now this is so sometimes the tumor can be multifocal. So this is multifocal RCC. So you can see this the tumors there, and then you can see there are multiple tumors. So so that's why in nephrectomy specimens, even if I found one tumor, I transversely slice to make sure there are any other multiple tumors, because you can see some multiple tumors. Particularly, it's common with papillary carcinoma. And in those situations, if there is no renal vein invasion, then we have to the TNM staging will be based on the maximum size of the largest tumor. So if this is the largest tumor, so if you measure that, so the TNM staging will be based on that. Okay, and again, multiple tumors have association with genetic alterations as well. Particularly if it is clear cell, then we have to think about von Hippel-Lindau syndrome. So again, multiple tumors. We have to identify them. So this is a typical appearance, not typical, but this is actually appearance of a chromophobe renal cell carcinoma, very pale brown color, and this is, you can see, a central nice area of necrosis. This is a chromophobe renal cell carcinoma. This, I think, everybody would have seen an example of this. This is a typically brown color a tumor with a central area of scarring. So anybody wants to guess what this tumor is? Central scarring, what they call
Oncocytoma.
Oncocytoma. Mahogany brown appearance. Yeah, that's good. So this is oncocytoma, very typical appearance. This is another example of an oncocytoma. But central scarring is a hit and miss. You might get it sometimes, you may not get it. But this brown color is very, very typical. And then I'm just moving on to just I know that the talk is mainly about renal cell carcinomas. I'm not going to touch urothelial cancers, but sometimes they might, the macroscopic appearance might overlap. So you need to identify whether it is. So this is actually a tumor. You can see it's a papillary tumor, but it is involving the renal pelvis, and you can see it is tumor involving into the renal pelvis. So this is papillary transitional cell carcinoma. So again, in those ones, we need to see whether it is involvement of the kidney or it is involvement of this peripelvic fat, which will help to differentiate, help in the staging. Okay, even this is actually a non-invasive papillary tumor, which is involving the renal calyces and involving the renal pelvis. Okay, this is high grade TCC, and just by looking at the location of the tumor, you get an idea that this doesn't looks like an RCC, and you can see the involvement mainly of the calyces, and then it's invading the hilum, and it's invading the upper ureter here. So this is high grade, again, invasive transitional cell carcinoma. It's going into the fat. And you can see the rest of the calyces are all dilated. That's another clue. So because if it is going to involve the renal pelvis, it's going to block the urine coming from the other calyces. So that will end up like a hydronephrosis. So when you see that appearance, then you have to think about, are we dealing with a TCC rather than a RCC? Okay, so this is another not very common tumor, very typical appearance, circumscribed tumor, very fleshy appearance. Sometimes you can have a cystic change. This is predominantly they behave very benign appearance. Anybody want to give it a try? Guess what this tumor could be? Very fleshy appearance, usually very solitary, and they, like oncocytoma, they have got a benign behavior. No, these tumors are WT1 positive, if that helps. Anybody wants to guess what this could be? So this is metanephric adenomas. So metanephric adenomas, again, they're thought to be arising from the remnant mesonephric remnants, and they usually have the very typical appearance. So this is metanephric adenoma. Okay, so nowadays I think more with robotics and laparoscopy, they're trying to do nephron sparing surgery, which is so they tend, if there is a tumor is more in the upper pole or lower pole, well away from the hilum, they tend to do these partial nephrectomies. So in partial nephrectomies, So the partial nephrectomy is the main you will not be able to assess the renal sinus fat or involvement of the renal vein and everything. But the key important feature, which important macroscopic thing we have to identify is how close the tumor is to the margin. So the renal resection margin is very, very important. So you can see here the tumor is abutting the renal resection margin, which is painted black here. So blocks from there will be quite useful. But overall, the appearance is typical of a clear cell RCC. Okay, so this is a chromophobe renal cell carcinoma where the patient had a partial nephrectomy, and you can see the renal resection margin, and then so that will be more useful. We may not be able to assess the other parameters, but basically the histological type, grade, presence or absence of coagulative necrosis, sarcomatoid change. So those are the features we can look for. So this is another clear cell RCC with a partial nephrectomy. You can see the red paint is the renal resection margin. So initially, so when you handle the specimens, before cutting into the specimen, identify the renal resection margin, paint it with some ink, and then slice it, so you will not miss the renal resection margin. Okay, so that's about the macroscopic. So what are all the features to look for, and how different types of macroscope tumor appears on macroscopic appearance. So this is, now we are going into microscopy. I think so the main, I'm going to touch only the main things which makes a difference for the which acts as a prognostic factor, because more and more I think the oncological management of renal tumors is actually expanding as we speak. So we see quite a lot of they want to know the specific histological type, because there are so many drugs available which can be used for different histological type. So I think that's overall the oncological development of the drugs has become has expanded so much that they want, the oncologists know the histological type better than us. They come and ask you, have you got this, have you done the genetics, have you they ask too many questions, and then we have to be we have to do we have to be aware of all these things, so that we can answer those questions. So again, histological type, as I alluded before this, there are very small different subtypes in the WHO classification. If a tumor, so again, many of these tumors will be clear cell carcinoma. If you got any tumor which is not clear cell carcinoma, then you'll have to think whether this could be any other entity, and then you have to take some further blocks and to make sure whether it is any of those rarer entities. This is the nuclear grade, a nucleolar grade, which is a very, very important, which is an independent prognostic factor, and they are particularly useful for clear cell RCC and papillary RCC. And for chromophobe, they have not been found to be useful. So mainly for clear cell and papillary RCC, which are the most common renal cell carcinomas, we should provide an ISUP grade. So ISUP grade is basically based on the nucleolar prominence. So what I do is when I look at the slide under 10x magnification, and just this is a clear cell tumor, and then looking at it and see if I can spot the nucleoli. If I'm struggling to look at the nucleoli, then I go to 40x, and if I can see a nucleoli at 40x, then that means it is a grade 2. And if you can't see the nucleoli even at that stage, then it is then it's grade 1. Okay, so grade 1s are I mean, usually you will when you put the slides on the stage, microscope stage, you will see them that they can't even see the nucleoli. It is just small. The nucleus itself is very, very small. So that is grade 1. This is grade 2, where you think that there could be nucleoli, but you need to go high power to confirm it. and nuclear grade 3 will just at 10x it will just hit you, and usually they have this alveolar kind of pattern. It's very alveolar pattern, and and then you can see the nucleoli will be just you can see the nucleoli without much effort. And then grade 4 is the sarcomatoid change. So you see either sarcomatoid change or very pleomorphic nucleus, very pleomorphic nucleus, or other thing is the rhabdoid nucleus. So this is the rhabdoid morphology where you've got cells with more abundant eosinophilic cytoplasm. So if you go sarcomatoid change or rhabdoid areas or pleomorphic nucleus, then it is grade 4. Okay, so that's the ISUP grading, nuclear grading. Coagulative tumor necrosis is very, very important, as I stressed before. So particularly for clear cell RCC and chromophobe. So you will see an abrupt transition from a viable tumor to necrosis. Because as I mentioned before, papillary tumors tend to have necrosis, but that necrosis, there seems to be the uncertain significance with prognosis, and they tend to get infarct very easily, papillary renal cell carcinoma compared to others. Okay. So, yeah, in coagulative, so the coagulative necrosis this is what means. So you got a viable tumor here, and then you can see a sudden, the cells are dying. What you're seeing is the nuclear debris. So what they say is the phenomenon is the tumor outgrow their blood supply so quickly that there is a sudden lack of blood supply and the tumor dies instantaneously. So this is important because it actually reflects the dividing capacity of the cells, or the doubling time, tumor doubling time. So again, that's why this has got more relevance, because the tumors which have got necrosis, they tend to grow fast, and that means chemotherapy or surgical management to get the tumor out is very very important for these tumors. So again, that's another example of coagulative tumor necrosis. So on the left hand side, you can see this is infarction. This is a long, this takes a while to get this this infarction area. We should not. This is not coagulative tumor necrosis. Coagulative tumor necrosis is where you see the nuclear deaths, and it actually you're going to abrupt transition from a viable tumor to this area, and this area we should not call this as a coagulative tumor necrosis. Okay, so other points which on microscopy, as I told you, perinephric fat invasion is very rarely seen, but microscopically you should see tumor in direct contact with the fat. You should not have any fibrous capsule, pseudofibrous capsule or anything. It should be a direct contact with the fat. Same with the perirenal fat, renal sinus fat as well. You should have a direct contact with the fat. And this is the one I mentioned before. In the renal sinus, you have endothelial lined spaces, looks like capillaries. Probably they are the venules. And though if there is tumor involvement into their sinuses, this is staged as PT3. Again, they have got high risk of renal vein invasion. Then and then invasion of the pelvic calyceal system. So this has been one of the tumor prognostic factors. It's lymphovascular invasion, which they're saying intratumoral or intrarenal lymphovascular invasion, which I found it a little bit difficult to identify, particularly with a lot of, because with all these tumors are usually have some area, some hemorrhage, fibrosis, infarction, all those things. So it's sometimes very difficult to spot these lymphovascular invasion. Then involvement of the adrenal glands, lymph nodes. So those are the other features. So again, I stress histological type is very important. Nuclear grade, coagulation necrosis, and renal sinus invasion, renal vein invasion. Those are the main prognostic features, which many of these things can be done at grossing itself. You can identify all these things in macroscopy, And microscopy, many times it's just a matter of confirmation. You take the relevant box and then you confirm. So that's so main kidney tumors, macroscopy is the key. I mean, you can accurately stage and type the tumor just by microscopy alone. So that's the end of my last of this renal tumor presence. So I just wanted to make it more practical and which can be used straight away, day-to-day routine. Are there any questions on this one, or can I jump onto the into the slide seminar straight away?
I think you can go to the slide seminar. At the end of the session, we
Yeah.
can address the questions, right? If
Sure.
you are okay with it. Yeah.
Yeah. Okay. Yeah.
So we have the students who will do the presentation of the slides. So they will do the slide description, and you can go about.
Okay. Yeah. So I will. Yeah.
The first slide will be done by Dr. Mercy from Madras Medical College. Dr. Mercy,
Okay.
you can unmute and do the description.
Do you want to view the web images? I'm not going to open the web images because it might just slow everything down. So I'm just
Okay.
going to wait. I've got a PowerPoint of the probably what I will do is I will yeah, let her describe the case, and
Yeah,
then
you can.
I will
Meanwhile,
also
you
show
can
my.
focus the PowerPoint. If you have got the image of that slide, you can focus that.
Yeah,
So
yeah,
that.
I'm going to do that. Yeah, that's what I'm
Yeah.
going to do. Yeah.
Okay. Dr. Mercy, you can unmute and.
Yes, ma'am.
So if you've got the history, you can read out the
Yeah.
history.
So
And
I'll
start.
tell you. I'll just talk about this one before. So this is actually a patient who had a previous partial nephrectomy for cancer, and then had a local difference, and then they were planning for a completion nephrectomy because there was a recurrence at the surgical site. And then they found on ultrasound they found some ovarian cysts. So they were about to take the kidney off. So I got a call from the theater saying that we were trying to take the kidney off, but then we found there is something in the momentum, and can you do a frozen section on that one? So we did a frozen section, and actually these biopsies is following the frozen section. So what they've sent. Okay. Yeah. Can you describe this one, please? No, I mean, just try to don't worry about anything. I just want you to get used to how to describe things, and then we can come to conclusion and differential diagnosis later.
Sections. Good afternoon, sir. Section studies show a malignant neoplasm arranged in nodules, diffuse sheets. The cells are large, round to polygonal with clear vacuolated cytoplasm and with centrally placed round to oval nuclei, many of them showing prominent nucleoli. These neoplastic cells are separated by thin fibrovascular septa.
Okay.
Here we can see in this power, we can see some mitosis and areas of hemorrhage.
Yeah. Okay. So yeah, that's fine. So at this stage, do you think what are your thoughts? So you said it's a malignant neoplasm. So what are your thoughts about this tumor?
Sir, it could be either a clear cell RCC, sir.
Okay. And yeah, okay, clear cell RCC. How do you then? What is the next stage? How do you approach this case now? So you think it is yeah, with the history and everything. How do you approach? How do you take it now? Yeah, you think it's clear cell tumor. Is there any
Yes,
differential
sir.
diagnosis, or you want to do something?
Yes, sir. Sir, I'll proceed. Sir, they have given USG shows solid and cystic elements, sir. So it could be either mets from ovary or mets from already the patient had RCC, sir. So it could be either mets
Okay.
from kidney or mets from ovary. I'll proceed
Okay.
on with the IHC, sir.
Okay. Okay. Yeah. So yeah, we can probably, but one thing you could do before doing the IHC is to know the correct histological type of the original kidney tumor. Yeah, if you can get that report from the previous tumor, because I have said only renal cell carcinoma, we don't know what's the histological type. Yeah, that will help definitely. So you need to know what the histological type of the tumor was. So when I say RCC, it could be anything, because RCC is a very common term used by the urologists. So for everything they will use RCC. So you need to know what histological type of that original nephrectomy. And you are right. So since there is a ovary solid and cystic, it could, that ovarian cyst could be a separate entity, or it could be a primary tumor and you might have metastasis. Yeah, go on. So what type of what immunohistochemistry you think it might be helpful? Again, this is something which I keep telling all the postgraduates. So when you do immunohistochemistry, you need to think about what question you are going to ask. So here we are going to ask whether it is, there are two different questions you have to answer. One is this metastasis from kidney or ovary? Yeah. And the second question is,
Yes.
if you then we, if you then I mean actually you might have to do it in two panels. The first panel will say whether it's kidney or ovary. The second panel will show whether this is then depending on it is kidney or ovary, then you might have to do further tests to identify whether this is, what is the histological type of that tumor, whether it is kidney or ovary. Yeah. Okay.
Yes, sir.
So what sort of immunos? Again, why I'm saying this: if you formulate the question, then you have to choose. Then you can choose the panel based on the question. Because if you just do immunos without thinking, then because immunohistochemistry, I mean, it's not black or white. There will be a lot of positivity, a lot of negativity, which you wouldn't have anticipated. You might have done something, and then it might be positive for some other tumor, and then you are stuck. We don't know how to interpret this. So if you go, so it has to, and also it has to go with the morphology. So you look at the morphology, you then identify what is the problem, devise the question. Okay, so this is the question I'm going to do differentiate between renal and ovary. So what type of markers I would do? Okay, so let's okay, I'm just asking the question. So if it is, for what markers you will do to differentiate between kidney and ovary? That's the first question we'll try to answer.
CK7, sir.
Okay, so CK7, okay, but
Paxate.
CK7, okay,
CD10.
okay, okay. So again, so ovarian, what type of ovarian tumor are you thinking about? By just with morphology,
Clear cell carcinoma of ovary, sir.
clear cell carcinoma of the ovary. Okay, okay. So CK7, I'm not 100% sure, but CK7 in clear cell, because CK7, if you're thinking about clear cell carcinoma, CK7 will be negative in
Yes, sir.
clear cell RCC. CK7 will be negative. Okay,
Yes,
clear
sir.
CK7. You're doing it for ovary. Okay, and then you
Yes, sir.
said what is the second marker you said was
Paxate, sir.
Paxate. Paxate can be positive in both. No, so I mean, Paxate is positive in. Is it positive in clear cell? Paxate is positive in serous tumors. Okay.
It's
What is the
not
third
positive
marker you
in
said?
CD10,
In
sir.
clear cells.
Yes,
CD10.
sir.
CD10 will be more positive in. Okay.
Clear cell kidneys.
Kidney. Okay. Okay. One more thing. I want to ask. ER will be of any use?
No, sir. ER will be negative in clear cell carcinoma of ovary, sir.
Okay. Napsin is the marker for clear cell carcinomas of ovaries. No. Do you know napsin A? Okay.
I'm
There
not
is
sure, sir.
Okay, yeah. Napsin A is a marker which is mainly used for pulmonary primary to
Yes, sir.
identify pulmonary tumor, but apparently it's been a good marker for clear cell carcinoma. Probably you can check the books about Napsin A as well. Okay, so yeah, so you're giving me the appearance of the okay. Now the next step is if I okay now the I, one of the question I asked was what was the primary tumor in the partial nephrectomy, and it was a chromophobe renal cell carcinoma. Okay, the primary tumor in the partial nephrectomy was a chromophobe renal cell carcinoma. Will that change your? But will this appearance will be? Does it look like chromophobe renal cell carcinoma? So you said about vacuolated cytoplasm. So do
Yes,
you know
sir.
what is the typical appearance of chromophobe renal cell carcinoma?
Yes, sir. The cells will have clear, well-defined cell membrane with
Yeah.
either pale vacuolated or eosinophilic cytoplasm, but the
Mhm.
nuclei will have wrinkled uh, nuclear appearance with a
Yeah.
perinuclear halo, sir.
Yeah. So if you can, if, I mean the ones we did, so we have got very prominent cell borders in this case.
Yes, sir.
Okay, and then we've got vacuolated cytoplasm. The only thing I agree with you, which is totally against, is the nuclear appearance. Usually you will have you won't have this very large nuclear with prominent nucleoli.
Yes, sir.
And also they talk about binucleation. So like here you got binucleation.
Yes,
So
sir.
again, binucleation is one of the features of chromophobe renal cell carcinoma. Um, so only factor which is against chromophobe in this case is the nuclear appearance, but we are dealing with a metastatic situation, so I don't know, probably the nuclear features may change with metastasis. So that's something you have to keep in mind. That's why I asked, immediately before you jump into the immunos, we need to know what is the primary tumor, because the common things are common. Metastasis from unknown primary is more common than a second primary. Okay, so
Okay, sir.
barring it, so I'm just this is just to this is not to what you have said is absolutely right. I'm just trying to for you to think and then do the panel and everything else. So in this case what I did was again I did all the all the markers you said. I'm just showing you only the markers which is more relevant to this case. So I did a Vimentin, and I think, sorry about, I mean, the pictures are not very great, but what you can see, it's the tumor cells are all negative, and it is mainly staining the intervening fibrous stroma. So the tumor cells are negative. So usually in RCC we expect a Vimentin positivity, yeah, which is completely negative in this case. And CK7, again, CK7 is strongly positive. Okay, again, CK7 positivity is, you can see it with ovary, you can see with chromophobe RCCs as well. Yeah. And then I did a CD117 because CD117 is typically positive in. Do you know CD117 usefulness of CD117 in renal tumors?
Chromophobe and oncocytoma.
Very good. So
Yes, sir.
CD117 is chromophobe and oncocytoma. So they are they are positive in both. And so how do you distinguish between chromophobe and oncocytoma if both are CD117 positive? Anybody? Because CD117 is positive in both. But one of the main problems with diagnosing oncocytoma or chromophobe, because they can look alike. There is a specific variant, which eosinophilic variant of chromophobe can look exactly like oncocytoma. Is there any other way to differentiate these two?
Hales
Special
colloidal
stain,
lines
sir. Special stain, Hales colloidal line.
So Hales colloidal line is very good.
will be
Hales colloidal
positive
line
in
will be used.
chromophobe.
Chromophobe, very good. Yeah. Any other immunomarker?
S100A1 will be
A1.
positive in oncocytoma.
Okay. Again, the same.
CK7 diffuse positive in chromophobe RCC, sir.
Very good. Well done. Well done. And CK7 is very strongly diffusely positive in chromophobe, but in oncocytoma, it will be very focal, one or two cells positive here and there, which is actually very quite useful, particularly if you get a renal tumor biopsy. So CD117 is positive in this case. So so again, this is nicely positive. So what I did was, in this case, I retrieved the slides from the original nephrectomy and compared with the tumor with this one. That's the first step I did, and then I'm not showing the immunomarkers. The Paxate was negative in this case. So based on this, I called it as a metastatic chromophobe renal cell carcinoma. Um, so um, so So this is actually metastatic chromophobe renal cell carcinoma. So as you mentioned, this one before prominent. So the typical chromophobe, prominent cell membranes, wrinkled nucleus, like almost like a coilocyte, coilocytic cells. You just have to imagine they look like wrinkled nucleus and perinuclear halo. Um, and then CD117 positive, and I mentioned before, diffuse positivity in chromophobe and focally only in oncocytoma. A Hales colloid line is useful, but unfortunately, we don't do it in our lab because there are some ingredient. I mean, some of the things in the Hales colloid line is not toxic. It's not good for the lab personnel to use it. So we have stopped using Hales colloid line, and very few of them can show sarcomatoid change. So that's also can occur. Um, and then just a syndromic association. There are occasional cases where it can occur with this bird hog Dubé syndrome, where where you can see oncocytomas and chromophobe same in this both mixed as hybrid tumors in the same kidneys, and they don't follow the same immunoprofile. Is completely it's not very straightforward. Um, but overall, the chromophobe, if you diagnose in the kidney, they got a better prognosis than clear cell RCC. But unfortunately, in this patient, the patient presented with metastasis from the chromophobe. Okay, so I think that is the end of this report. So hope it was useful. I'm trying to just first we have to use the morphology, ask the question. So if you can't do it in the morphology, you have to ask the question, and then if you got previous history or previous report, then try to get those reports. Number two, then devise the question for immunohistochemistry and do the immunopanel, and then you can come to a reasonable conclusion in many of these cases. Okay. Any
Okay, sir.
questions? Do you want to ask any question? Then
If there are
not, we
any
can.
questions from YouTube, can one of you read off, Dr. Sudha? Or, if there are no questions, we'll go on to the next slide.
Yeah. Okay.
Okay.
So next, we'll go to the next one now.
Next slide. Dr. Bhupati will describe some MMC.
Okay. So next patient is so this is so patient had again said right renal cell carcinoma. Okay. Yeah. So this is a patient had a previous renal cell carcinoma. So there was so they found a metastasis in the proximal pancreatic body. So since there was only a single solitary metastasis, they went ahead and removed the distal pancreatectomy and spleen. No, spleen is preserving distal pancreatectomy. Okay. So we've got the slides from that case. Okay.
Yeah, Dr. Bhupati, you can start describing. You can unmute yourself.
Yes, ma'am. Good afternoon, sir.
Yeah, go on.
Section studied showed a malignant neoplasm composed of neoplastic cells arranged predominantly in solid sheets, also in nodules and nests. The neoplastic cells are exhibiting moderate amount of clear cytoplasm, centrally located round to oval nuclei with inconspicuous nucleoli. Some of the cells are exhibiting conspicuous eosinophilic nucleoli, which is visible at 40x. Mitosis 5 to 6 per 10 hyperfield. Atypical mitosis are also seen. The neoplastic cells are separated by thin fibrovascular septa in some foci. The intervening stroma showed congested blood vessels, lymphocytic infiltrate, areas of necrosis and hemorrhage. The neoplastic cells are seen infiltrating into the adjacent pancreatic parenchyma.
Okay. Yeah.
So
yeah, what yeah, go on.
So clear cell renal cell carcinoma, sir.
Okay. Yeah. So that's fine. Are you happy to call it clear cell carcinoma? We don't want. Are you confident to call it a clear cell carcinoma? You don't want to do anything.
I will proceed with the immunohistochemistry, sir.
Okay. Yeah. Okay. Do you need immunohistochemistry, or you're happy just with morphology itself?
Morphology
It's okay.
is
That's fine.
assuring,
Yeah,
sir.
go on. Yeah.
Yeah. But
It's
anyhow,
very,
to
yeah.
confirm, better go with immunohistochemistry,
Okay.
sir.
Okay. Okay. Yeah. So what immunomarker will you would you want to do?
Sir, PAX8,
Yeah.
Vimentin,
Yeah.
CK7, sir.
Yeah. And what do you expect PAX8 to be PAX8 and Vimentin to be positive or negative? You can
Both
give
would
me
be
the
positive,
marker.
sir.
Just tell me what do you expect in clear cell tumor as well, please.
Sure. PAX8 will be positive. Vimentin will also be
Yeah.
positive, sir.
Yeah.
CK7
Yeah.
will be negative, sir.
Okay. Okay, good. Okay, so that's fine. Yeah. So I was just I totally agree with you. Only thing I would just do is again, as I told before, one of the important steps we keep forgetting is we need to look at the what the original tumor is. That's something. Um, uh, if you can get the report of the original tumor where it was done, just the report, just to see whether it is clear cell carcinoma, then it is more reassuring that this is also looks like that, so it will fit with the macroscopic appearance. So I would try to look at the previous to see what the type is, and then you can do immunos. This one I don't think I did immunohistochemistry because I compared and it looks like clear cell carcinoma. I'm confident that this is clear cell carcinoma. And the key thing I wanted to again want to reinforce, I mean, this is a very common tumor. This is what you get all the time. So this you get these clear cells separated by this thin fibrovascular stroma, and this clear cell appearances because of glycogen, and this very packeted arrangement is very, very typical. Um, um, and the only thing other thing you can see here in this power, you can see the pancreatic acini there. You can see almost in this power itself, this is actually a 5x magnification. You can see this part of the tumor looks different from this part of the tumor. This part is more alveolar appearance, and this is more nested appearance. And this probably is a grade 3 tumor. This is a grade 2 tumor. You can see those are the tumors. These are the ones, the higher, higher grade tumors. And when they one of the things which we found was when they metastasize, you usually see this type of pattern, alveolar pattern, and this alveolar pattern is quite strongly the main marker which is helpful in metastatic situation is PAX8. The other markers tend to be, sometimes it may be present, sometimes they might express, sometimes they may not express. But PAX8 is a very good marker when you're thinking about metastatic RCC, because RCC is one of the tumors which can metastasize even 10 years, 20 years after the initial diagnosis of clear cell RCC. So they can, and often we see with patients coming with hip fracture, they do the knee fixation and they send the in the fracture site, and you will see RCC metastasis. So that's common location. The other thing, we have seen quite a few cases of RCC going into pancreas. I don't know why but they tend to have they tend to go into the pancreas, and then they do if there is solitary metastasis, they do resection. And again, now the way they're treating this metastatic situation is changing. If it is solitary metastasis, even in lung, liver, or anywhere, they go for resection. It's no more palliative kind of treatment. They go for resection, and so again, diagnosing them is very important. What I'm trying to, so yeah, so they are the most common ones. So they tend to have mutations in VHL gene. If it is germline, then it is von Hippel-Lindau syndrome. So we have to think about other manifestations of that syndrome. And when the tumors are more than 7 centimeter, then if you measure the tumors as more than 7 centimeters, then you have to take more blocks on the renal sinus to see, because often they tend to have renal sinus invasion. So those are the markers. So other markers we started using is this carbonic anhydrase 9, which is actually a good marker for clear cell RCC. Again, we use PAX8 these markers for diagnosis. Um, this I already this I just keep repeating the same thing. This is grade, necrosis, sarcomatoid change are all very we have to look for it. And one other thing which I don't know whether you have seen, you can get RCCs which are completely cystic. There are no solid elements, just cystic, covered by a fibrous capsule. They have been now separated from the clear cell RCC as a separate entity in the WHO, which is called a multilocular cystic renal neoplasm of low grade malignant potential. So those tumors, what we'll have is you have only cystic structures, and they are lined by this clear cells. So you will have to do a cytokeratin to prove they are clear cells and not histiocytes. So those tumors are, they don't have any they got very good prognosis, they don't have any metastatic potential, and those are the ones we have to, if there are those are the ones usually they say cystic, multicystic on imaging, and they might they might do a resection because of the larger cyst, and those are the ones will turn out to be multilocular cystic renal neoplasm of low malignant potential. So that's something to keep in mind if you got a tumor which is completely cystic. Okay. I think that's the end of the report. So that's really good. So this is actually I just put this one because you can get this clear cell anywhere. You can get it in skin, in lung, anywhere, and they can present complete after 10 years after the initial presentation. So if you got clear cell anywhere in the with the typical appearance of this packeted appearance, think metastatic RCC first before anything else. That's the reason I put this one. Yeah. Okay. There are no questions. We can move to the question case
Slide
3.
3. Yeah. Dr. Himana from Stanley Medical College.
Yes, ma'am.
Yeah.
One second.
Once again, let him project the slide, then you can.
Yes, ma'am.
Yeah.
So participants,
this is,
if there are any questions, you can post them in the chat box even, and we can, the
Yeah.
speaker would address all those things at the end of the session,
if I know the answer.
yeah,
If not,
no.
if not, I'll ask Padma madam to answer the question.
Okay, let's.
Okay. Yeah. So this is a known non-small cell. The patient had a lung cancer, had radiotherapy, and then they found a CT lesion, right kidney lesion. So they biopsied it just to know whether this is primary renal or lung, or lung metastasis. So basically that's the main. So we are getting a lot of these tumor biopsies for renal tumors. So they usually do a biopsy first before they do the surgery. For example, if the biopsy turn out to be renal oncocytoma, then they don't do nephrectomy, because it might just to preserve the renal function. So they are more and more doing these biopsies nowadays, which is quite tricky because sometimes it's not representative of the whole tumor, and we struggle a bit on those ones. So I think I included some of the biopsies so that you can get the experience of how to deal with biopsies as well. Yeah. Okay. Next one. Yeah, go on.
Section study shows 5 linear course of renal parenchyma with infiltration by a malignant neoplasm composed of cells arranged in sheets and in focal glandular pattern. The neoplastic cells are round to oval with moderate amount of eosinophilic cytoplasm and hyperchromatic pleomorphic nuclei, with some cells having vesicular nuclei with prominent nucleoli. Impression is infiltrating adenocarcinoma, probably secondary to lung cancer.
Okay. Okay. Now if you okay, so what do you want to so okay, so you think it's a lung cancer straight away. Can it be any will you consider any primary cancer of the kidneys, primary tumors?
Yes, sir, have to be ruled out. Primary also.
Okay, so what tumors of the kidney you will think about, or you are confident that this is lung? Okay, just what? So let me put this question this way. Um, what primary kidney tumor can look like this. You described it's glandular, it's very pleomorphic, prominent nucleoli and everything. Um, yeah, is there any primary kidney tumor which can look like this? Okay. So I mean the main don't worry, I'm just asking because again, many of these things, if you just think logically, we can come to a reasonable conclusion, and then we can then do further tests to identify. So that's the main idea. I just want you to just think, and then yeah, you are right. It could be metastatic lung, and or it could be a primary. So in the primary tumor, I usually put them into these high this is all very pleomorphic, prominent nucleoli and everything. I put them into a category called high grade tumors in the kidneys. Okay, in the high grade tumors, so usually the ones which you included in the high grade tumors is TCC. You should not forget about TCC, because if you think about, if you look at this tumor back, they are more um, almost involving the tubules. It's got a very tubular it looks like it's involving the tubules. Some of them, I agree, it has got a acinar kind of pattern, and also they can be very pleomorphic. They can differentiate into squamous or adeno. Transitional cell scans can do anything, and so that's something we need to keep in mind. So that's one of my differential. Then number two is you got other pleomorphic tumor, like collecting duct carcinoma is one of them, which can also have this similar. It's an adenocarcinoma of the collecting ducts, and then you tend to have a lot of desmoplastic stroma, and then you got medullary carcinoma. They can also show very pleomorphic. So those, and then in this case we have to think about metastatic lung. So I would say those are the four differential. The three I mentioned, that is the collecting duct carcinoma, transitional cell carcinoma, and medullary carcinoma. All those three, I lump them together as the high grade cancer. So when I see something like this, then I know I'm dealing with one of them. Then the next step would be to do immunohistochemistry. Also, similar to the previous two cases, I would also like to know what was the original lung cancer, because they said non-small cell. Non-small cell means it could be squamous, or yeah, can be adenocarcinoma. Okay, so it could be one of them, and then what we might be looking at, it's a poorly differentiated squamous cell or a poorly differentiated adenocarcinoma. We got some glandular differentiation, but you can get pseudo glandular appearance in a squamous as well. Okay, so that's good. So do you have any what immuno? So I'll just show you some immunos. Let me know what you think. Then, but this is like slightly a complicated case. I just put it just so that you need to know what other entities and what immunos can be helpful in this situation. That's the whole idea of doing this case. Okay, so in this case, I've done a CK7. Yeah, what do you think the tumors? Is it expressing or it's not expressing?
Dr. Himana, if you are able to see, you can answer.
Yeah, please. Just what do you think this is?
If you're unable to answer, you can always say you are unable to.
That's okay. Yeah. So what you can see, I'll help you out. Don't worry. What you can see is you can see the tubules. So there are normal tubules which are expressed. Which are expressing CK7, and then you can see these tumor nodules, which seems to be not taking the stain. Okay, so this is not that these tumor cells are not expressing CK7. So now you think about it in your differential. We have got lung primary. If it is lung adenocarcinoma, then they are CK7 positive. Okay, and then number 2 is if this is if it is TCC, they should be CK7 maybe positive. Again, it's not things. Other thing, medullary collecting duct, and this they're all variable staining with CK7. Next, go to CK20. This is completely negative. AMACR. So so Amakar is seems to be I don't know these are I don't I think the main tumor nodules are all seems to be negative. I'm just showing you the immunos I have done at that time, because one of the yeah, so that's Amaka. Now CD10. So CD10 again, it seems to be like weak expression, background staining. The tumor cells seems to be not very important. One of the key things when interpretation of immunohistochemistry, always compare with the HNE, and then you need to look at the specific cells to see if they're positive or negative. Sometimes if you just look at it in low power, we might end up saying positive or negative, but actually when you look at the high power, then we can see all the tumor cells seems to be negative, and this CD10 is picking up a lot of lymphocytes and a lot of other things. So that's something which I would pay more attention to. So this is the RCC marker. Again, RCC marker is negative. It stains only the tubules. So yeah, I've done TTF1 because there was a previous history of lung cancer. So the CK7 is negative, TTF1 is negative. And the primary tumor was, I think it's adenocarcinoma. So that is all negative. So this is P63. So you can see the tumor cells are nicely highlighted by P63. As you know, P63 is a marker, is a high molecular weight cytokeratin. I use it for multiple areas. So one thing we use for squamous differentiation. So P63 and P40 are both are for squamous cell carcinoma. So they're quite well expressed, very well P63. And P63 can be used in prostate biopsies when you are thinking about these stains the basal cells very well. So in adenocarcinoma, the basal cells are usually negative. So P63 is a very good marker for prostate cancers. And number 3 is the P63 is useful as in urothelial cancers. So P63 is a very good marker for urothelial cancers. So so those are the 3 cases. So what I think there are some other markers which are help to differentiate, which we don't have it in our lab, but I will go through with this one. So this one is actually I've just lumped it as a high grade carcinoma. Because of the P63 positivity, I called it as a TCC involvement, and also because the original lung cancer was was adenocarcinoma, CK7 positive and TTF1 positive, which is not in this case. So that's why I concluded as a TCC. But main idea of putting this case is to identify these high grade tumors, and as I told you before, these 3 fall into the category. So it's in the books and some papers it is referred to as distal nephron like carcinomas. So you got so these are the 4 markers, which are 4 or 5 markers which is suggested. INI1, which is a typical marker which is lost in medullary carcinoma. OCT4, not 3/4, it's OCT4, which is positive in medullary carcinomas, which are negative in others. Again, GATA3 and P63, which is positive in TCCs. You have to remember GATA3 is also positive in SCCs. If it is a if it is a primary lung squamous cell carcinoma, then it's not possible for me to differentiate because they will express the same markers. I will be in the same position before. So I would say it's not possible to say this is metastatic squamous cell carcinoma from the lung or it is a TCC. Then next is PAX8 positive in collecting duct, which is negative in TCCs. Okay. At that point of time, we didn't have Paxate. Now we have got Paxate. This case is a little bit older, so I couldn't get the Paxate done at the time. Um, uh, so this one, so just so these are the three differential diagnoses for you to think about, and then usually they have the same pattern. Like they can have solid, tubular, papillary growth pattern, and they have got stromal reaction, inflammation. All these morphological features are shared by these three tumors. Okay, so that's the end of this case. Any questions? I think this is slightly complicated, but I wanted to show you the different type of renal tumors, what you might get the regular practice. So can we go to question
Slide
4?
number 4.
I think
Yeah.
we've got 45 minutes so that we can go through the next 4 cases
Yeah.
or 5 cases.
Dr.
Actually.
Selvi, Dr. Selvi from Stanley. Dr. Kailash.
Yes, ma'am.
Yeah, you can present. You can describe the slide.
Case number 4,
Yeah, so this,
ultrasound fatal left section biopsy. Section study
Yeah.
shows 4 linear fragments of renal parenchyma enclosing neoplasm composed of cells arranged in papillary pattern with fibrovascular core. The papillae are lined by columnar cell having moderate amount of eosinophilic cytoplasm with hyperchromatic pleomorphic nuclei and nuclear pseudostratification. Some of the cells shows vesicular nuclei with prominent nucleoli. The fibrovascular core contains few macrophages and congested blood vessels. Impression, papillary renal carcinoma, type 2.
okay. Okay. So, okay, that's okay. Do you want to include any other differential diagnosis, or you're happy this is papillary RCC? I'm just showing you the high power,
Papillary
just to
RCC.
okay, that's fine. Okay. Um, so that's a good description, and I think that is one of the things I thought about. Even though it doesn't have the full papillary architecture, sometimes you can have a solid papillary feature. And also it's also sometimes it's you see here, it's some areas it's almost like um, very the stratification of the nucleus, and oh, I forgot what's the name of the pattern. Okay, okay, let's go to the okay, the papillary was in the differential diagnosis. Okay, so I did some immunomarkers. I will show you the immunomarkers. So what do you expect in the papillary tumors? What markers do they express?
Dr. Selvi, papillary RCC markers. If you know, you tell. Otherwise, you can always say.
Anybody can say. It's not
Yeah,
particular
yeah.
to Selvi. Anybody who this is just a discussion, informal discussion. Yeah.
CK7 positive, RCC
Yeah.
antigen positive, CD10 positive, sir. Carbonic
Yes.
anhydrase 9 will be negative.
Negative.
And
Well then.
EMA AMACR may be positive.
Amakar is positive. So the key markers what you said is completely right. The markers I usually rely on CK7 and AMA Amakar. But CD10, all those things can be it will be useful as well. But combination of CK7 and Amakar both will be positive uh, in RCCs and clear in papillary RCCs, and carbonic anhydrase 9 will be usually be negative. So those are the markers I've used. So I did those markers. Okay. I will come back to that one later. Okay. So that's the CK7. So we got the normal kidney tubules. So always what we call as the internal control. Always look for internal controls in your tissue to see whether the immunos have worked very well. Because sometimes in this automated immunohistochemistry, if the reagent hasn't reached the sections, you might get a false negativity. So having some internal control is quite always be reassuring that the immunos have worked. Okay, so what we have seen is here we have got um, tubules, and then you see the tumor. I've just compared. That's a normal renal parenchyma, and then the tumor is CK7 negative. At this point, do you want to include any? We don't expect CK7 to be negative in a papillary. Do you want to bring in any other differential? So CK20 is also negative. Anything else? So the CAM 5.2 is positive. So it is clearly epithelial origin. I did WT1 because just to exclude because of these very basophilic cells close. I mean, even though it doesn't look like typical metanephric adenomas, I did WT1. um, I mean, I was surprised by the initial panel. So when I did CK7 cam, I was negative. I was surprised, and then went back again. When you don't have any typical appearance,
Any
then
neuroendocrine pattern,
yeah,
neuroendocrine markers?
very good.
This
So
is
that's I think very good suggestion. That's what when I so when you usually I do a single first panel, and if you don't get the expected answer, then I go back to the sections and then see if go back to the HNE and then see if I am not. So that's when I started seeing some granules, and um, fortunately for me, since I do GI as well, I see a lot of neuroendocrine tumors. So I thought, "Oh, this looks like a salt and peppery chromatin or stipple chromatin. So I need to have to do any so I went back and did synaptophysin. So it's completely positive. Yeah. So good suggestion. So this is actually, so I did a TTF1 as well. Chromogranin was negative. So synaptophysin is a very useful marker for neuroendocrine differentiation. Um, uh, so I do synaptophysin and chromogranin if I'm suspecting neuroendocrine tumors. So this is a well differentiated neuroendocrine tumor, which can occur as a primary tumor in the kidneys. So if you go back to the WHO classification, we have got three categories in the in the neuroendocrine tumor: well differentiated neuroendocrine tumor, which is similar to your GI. Carcinoid is the older term, and with a neuroendocrine tumor. Then you've got small cell and large cell, similar to a lung um, classification. So you've got three tumors in this category. They're often seen with horseshoe kidney. Again, typical appearance, well-defined tumor, yellow. But the key thing is first, first again, I will ask the question whether this patient had a previous neuroendocrine tumor, because metastasis is more common. This could be metastasis from GI. So that's something we need to think about. And then the immunoprofile is typical net immunoprofile. I don't know whether you know about, they can also express PSAP, prostate specific acid phosphatase. If you happen to do that, these neuroendocrine tumors, they tend to express PSAP as well. And they're usually present with METs, but well differentiated neuroendocrine tumors, they even with metastasis, they've got better prognosis than small cell or large cell tumors. So this is a common tumor in an uncommon location. So again, morphology is very keen, and so that's other key learning point from my experience is if the first panel doesn't answer what you expected, go back to your HNE. Many of the times HNE you will give you the answer, or at least you have to think differently, and then you will be able to get to the answer. Yeah. Okay, so that's with this case number.
So this was
4.
a primary or metastatic?
It was a primary. It was a primary. There was no tumor elsewhere. So this was a primary carcinoid or a neuroendocrine tumor of the kidneys.
Okay. 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 I think
Yeah.
there are no questions. We will go to the next slide. Dr. Anantanarayani from Stanley.
Yes, sir.
Just wait till he projects the slide.
Yeah. So this is a large renal mass. The patient presented with bone metastasis, and this was a very young patient, 30-year-old, 35. So the clinical question was RCC or whether it is a lymphoma. The patient had also had a rib lesion. They tried to biopsy the rib lesion, and that was, I think, that was the site of bone metastasis, and that was inclusive. So they went ahead and did a biopsy of the renal mass. Yeah.
Section study shows fragments of benign neoplasm composed of cells arranged in nests, islands, trabeculae, tubules, and in microcystic pattern. The cells are large, having abundant granular eosinophilic cytoplasm with centrally placed small round nuclei having smooth regular nuclear membrane and evenly distributed chromatin. Hypocellular edematous stroma seen, no mitotic figure seen. Also seen a few congested blood vessels and focal chronic inflammatory infiltrate. Impression oncocytoma.
Okay. Very good. To be honest, I was also thinking about on. Then I was thinking why this patient presented with bone metastasis. Sometimes clinical information is quite help you to think laterally. So there's a large renal mass with bone metastasis because we know renal oncocytoma is more benign tumor, and why it has to present with bone metastasis. You can argue that may be a different second tumor, but again, common when you got tumor with the metastasis, we usually think it is a single tumor which is causing the metastasis. Yeah.
Yes, sir.
Okay. Any other? Yeah, that's fine. Any other? Anybody wants to add anything to? Are they? So it's got a very granular kind of cytoplasm. The one thing with oncocytoma, usually tend to have tubules or nodular. Then you'll have this intervening stroma which looks very edematous. This seems to be a diffuse sheets. And one of the things I noted was some pale vacuolation in the cytoplasm. So one of the pale vacuolation, and then I see. Look at this eosinophilic kind of material or something within the cytoplasm. Then I went back to books. Sorry. Very good. Yeah. I mean, sorry, go on. I heard SDH. I heard. I didn't hear the next line. Can you repeat, please?
Diffusion renal cell carcinoma, sir.
Yeah. Very good. Yeah. So I mean, to be honest, at that time I have not seen a case before, so I have to go, given the age and everything, and I wanted to, then I had to go to books and then look at what is there any other tumor which can look like oncocytes with this, and then try to see what this pink material is. And then again, but they have got very bland kind of nucleus. So I did immunos, CK7, it's completely plasmacytoma. Okay. Okay, that's fine. So yeah, okay, the same. Yeah, okay. Let's do let's see the immunos, how it's helped. So you can see the CAM5 point is completely negative. It was completely negative. CK7 was negative. And then CD117, it's actually not. I don't think it is. It's highlighting only the it's mast cells or something. It is not staining. It's not the tumor cells are basically negative. So I was thinking of oncocytoma like who presented it. So CD117, CAM5.2 was negative, 7 was negative. I was stuck, and then RCC markers was negative. So at this point, I thought this is, and then CD10, you can see some expression with CD10. Okay, so at this point, the patient was not doing very well, and morphologically, I thought, I did synaptophysin as well, like the previous case, because of this granular kind of cytoplasm. We go back to the image, you can see it's very granular kind of cytoplasm. If somebody says this patient has, if you think about carcinoid tumor, it could be So I did synaptophysin and chromogranin, and they were negative. And then at this point, I was thinking of SDH deficient. And then I have to read the books, and then often I think there are majority of them do very well, but some can present with bone metastasis, and it can occur in the younger age group because of these germline mutations in the SDH. So I sent the tissue to somewhere else where they did the molecular the sequencing of the SDH gene, and they found the loss of SDH deficient. So this is actually an SDH deficient RCC. So very rare, young adults, and they can present with metastasis, strong family history. So that's very important. So once you identify somebody, then family history, there can be germline mutations, usually well circumscribed, and neuroendocrine, like low grade nuclei, eosinophilic. So these are you can have flocculant and bubbly appearance. Um, and, and the immunohistochemistry, the key immunohistochemistry is the loss of this SDHB marker. PAX8 may be positive, but cytokeratins are frequently negative. So, and it's negative for all these markers. So neuroendocrine markers, RCC, carbonic anhydrase. Again, majority of them low grade, but unfortunately, this patient we had actually died after a month of diagnosis. So again, this is a rare tumor, but identifying them is quite useful for probably for the family, and also you need to have if again similar to the previous case, if you do the preliminary panel, you think oncocytoma, do the immunos, and then if it doesn't match, then you have to think whether are we missing something, or is there anything, can it be something else. So neuroendocrine tumor was made in a differential, um, and then SDHB was in the differential, and then finally it turned out to be SDHB. Okay.
The bone biopsy was the report?
Yeah. Sorry.
Bone biopsy, was there any was that?
No.
Biopsy?
It had only. I think it didn't. They had only the cortex, bone cortex, and skeletal muscle. There was nothing in the. There was no tumor in that one.
Okay.
But I think most likely this patient, probably what we have got in the biopsy is probably the low grade aspect of it. I suspect we haven't got the high grade, necrosis and high, and that's why it looks like very bland kind of appearance in our biopsies. But again, many of these tumors, if it's a huge tumor, you can have a variation of sampling error, where we may not, the biopsies may not be representative of the high grade areas.
Okay.
So probably this patient had a high grade area somewhere, and then that probably that probably led to his metastasis, and then he died because of that. Yeah.
Okay. Yeah.
Okay.
It was a totally different case. The next presenter will be Dr. Anand from Coimbatore Medical College.
Hello, sir.
Okay, so this is hi. So this is a nephrectomy. I don't know. This Bosniak term is used by radiologist. I don't know. They use different grading to identify whether the renal cyst is neoplastic or it's more on the benign end of the spectrum. So this is Bosniak 4, which is they are worried about. There is a neoplasm. So when they say Bosniak 4, then they suggest nephrectomy because to exclude cancer. Okay, and usually cystic lesions, biopsy is not very useful until otherwise there is a solid lesion, because you may not get the relevant the tumor cells in your biopsy, which will help you in the diagnosis. Okay, yeah, go on.
Section study shows well circumscribed renal neoplasm composed of varying size of tubules from small to cystically dilated. They are predominantly lined by a single layer of cuboidal to columnar cells. Individual cells have eosinophilic granular cytoplasm. The nucleus are round to oval with prominent nucleoli. Papillary tufting are seen at some of the cysts. The cysts are separated by a thin fibrous septa, and cluster of tumor cells and hemosiderin-laden macrophages are noted within the fibrous septa. There are no solid areas noted and necrosis not seen. Normal renal parenchyma is seen at the peripheral rim of the tumor.
Very good.
Here, I have a differential diagnosis. Most probably, this is tubulocystic renal cell carcinoma, but I have to rule out multilocular cyst renal cell neoplasm of low malignant potential, sir.
Okay. Very good. Yeah. What is against the second diagnosis in this, just by morphology?
By morphology, multilocular cyst is mostly clear cells, but rarely they do present with granular cytoplasm.
Yeah. Very good. Very good. Very good. Yeah. Well done. Yeah. So that was my differential as well. Only other thing I thought was because of his very granular appearance, whether it's an oncocytoma with a very cystic component, because you can have cystic change with oncocytoma as well. So are we dealing with the oncocytoma with the cystic one? Yeah, very good. Good description and a good differential diagnosis. So I did immunos. Again, it is CAM positive and AMACAR positive. Okay, so we don't, in a clear cell RCC, we don't expect AMACAR positivity. It was CD117 negative because I wanted to exclude the oncocytoma, and CK7 is negative. Okay.
Okay. Then this is tubulocystic aggressive.
Yeah, it is. It is. So it is CD10 nicely positive, CD19, and this is a tubulocystic RCC. I mean, it is very typical appearance. See, this is the macroscopy of that case. You can see it's very multiloculated cyst. And whatever, this is all just edematous stroma. You don't see any solid areas. Very typical appearance. It's not very common, but when you see it, macroscopically you can diagnose them, and microscopically it's quite useful. And as you mentioned, that is the differential multilocular cystic renal neoplasm, low grade malignant potential. Cystic nephroma, they can also look like this. So if you there is a pediatric one and adult one. A pediatric one is more associated with the nephrogenic rest and everything. Adult one, you tend to have ovarian type stroma in the cystic nephroma. So it will be multicystic lesions lined by cuboidal epithelium, and you've got ovarian stroma. And then other thing is the acquired cystic disease. The patient has got previous renal problems. Then you can have cystic disease associated RCC, and there you will look for these refractile oxalate crystals, which will help you in the differential diagnosis. So, and for some reason, it affects mainly the males, and well circumscribed lesions, almost like spider web like fibrotic stroma. So when you look at this one, it almost like spider web like appearance. That's very typical of tubulocystic RCCs. Again, Paxate and AMACA are quite useful, and focal carbonic anhydrase and CK7. So it has a very good prognosis. So again, it's a very typical appearance. And yeah, if macroscopy and microscopy is quite typical for diagnosis of tubulocystic. Okay, good, well done. Yeah, let's go to the next one. I'm just trying to do it. I don't want to take finish on time so that it won't disturb your regular.
Even if it gets extended by 10-15 minutes, not to worry.
That's okay. Yeah.
Slide number 7. Dr. Pravina, Coimbatore.
Yeah.
Hello, sir.
Hello. Yeah. So this is a right partial nephrectomy for a tumor. Yeah.
Dr. Karthik, Dr. Dhanalakshmi is the HOD in charge now in Coimbatore, for your information.
Oh, okay. Okay. I saw her name in that list.
Yeah,
sure.
These last 3 slides, they are presented by Coimbatore students only.
Yeah, Coimbatore. Okay. Yeah. Fine. Okay.
Okay, sir.
Yeah.
Section studies show a circumscribed renal neoplasm with a thin pseudocapsule. The tumor is composed of neoplastic cells arranged in multiple patterns, predominantly
You carry on.
Okay, ma'am. The tumor is composed of neoplastic cells arranged in multiple patterns, predominantly in tightly packed tubules, papillae, pseudopapillae, and nested pattern. A single foci shows tumor cells arranged in typical alveolar pattern. In this foci, the tumor cells are medium to large size polygonal cells with central round nuclei, abundant clear cytoplasm, and distinct cell borders, with a mild nuclear atypia and an ISUP nuclear grade 2. The tight papillary cluster shows central fibrovascular cores with the red blood cells. In all other foci, the tumor cells were arranged in closely packed tubules, which are separated by thin fibrovascular septae. These cells have a little similar morphology to the alveolar pattern, and they have a eosinophilic granular cytoplasm and a higher nuclear grade. Areas of edema and focal areas of hemorrhage are noted. Most of the blood vessels are hyalinized. Adjacent renal parenchyma could be noted, which is well delineated from the tumor. The ink marking at the margin shows no tumor cell infiltration.
Very good. Yeah.
So I was thinking about I could see prominently a clear cell area in a foci. I was thinking clear cell renal cell carcinoma with clear cell papillary renal cell carcinoma like features. I was also thinking whether it is a collision tumor, whether it's some areas are having little higher grade nucleus. So maybe it's a collected carcinoma along with the renal clear cell renal cell carcinoma, or whether the clear cell area could be a microtumor also, sir. I'm not sure whether.
Sure. That's okay. Yeah. So I think I agree. Very good description. I think you have nicely said about this closely packed tubular structures. So you've got two components which you have identified: clear cell and also this closely packed tubular architecture. Okay.
Yes.
So again, yeah. So common things common. So you've got clear cells and then you've got this packed tubular architecture. Are we dealing with clear cell which is showing some changes, or is it clear cell papillary? And that was my initial feature. So the other thing you have to think about the other way as well. So is it a papillary tumor with some clear cells as well? You can get because papillary tumors can also have this tubular architecture. Sometimes you can have this solid papillary variant, which can also look like this. So those are the differentials. One other thing I wanted to highlight in this case, whether I don't know if you noted, I'm just focusing on this picture. This is a clear cell area. Is there anything which is very? Can you observe anything on this? Just look at this one gland and then see what is there anything you can observe on that one, which I want to highlight.
Sir, the nuclei are away from the basal aspect of the cell, sir.
Very good. Very good. Well spotted. Yeah, that's very well spotted. That's one of the very useful feature of this neoplasm. It's almost like a secretory kind of endometrium. Just remember, like a secretory of endometrium where there is more secretions inside the nucleus is pushed to the luminal aspect of the cell. So that's something which is very typical of this condition. So immuno-wise, the differential you said, what will be useful? How will you differentiate? Like let's take two at the time. So you're saying clear cell carcinoma with papillary areas and a clear cell papillary. How do you what immunos might be helpful in differentiating these two entities?
Sir, CK7 will be the first choice, sir. It will be negative in clear cell, and clear cell papillary will be positive for CK7.
Okay. Yeah. Very good. Yeah, I've given you the thing. Okay. Anything else will be useful. So it's clear. It's you can see that all the tubules are nicely bringing up it CK7. How about I said the
carbonic
possibility of
anhydrase, sir.
Yeah. What will happen to carbon anhydrase with clear cell RCC?
It's positive in clear cell, sir, and negative in papillary.
Sir, it shows diffuse membranous positivity in clear cell RCC, sir. Whereas in clear cell papillary RCC, it show cup-like positive.
Very good. Very good. I think yeah.
CD10, sir.
Yeah. Very good. Yeah, that's cup-like positivity is a very important thing. So usually you get a full membranous positivity with clear cell RCC with clear cell papillary. You get this cup-like positivity. I think again I don't have carbonic anhydrase because we got the antibody recently. It stains nicely on the sides and the. So usually with this carbonic anhydrase, it stains the basal aspect. It's almost like a number Tamil pa letter Mari. You should stain only the sides and the base. So that is the typical appearance of clears of confounding anhydrous. I did AMACA because one of the differential I said was this could be a solid papillary RCC with we can get some clear cell areas. Okay, so that one is AMACA. So that for that one I did AMACA because solid papillary it should be AMACA positive. Okay,
Yes, sir.
CD10.
CD10
Again,
is
you expect
negative
it
here, sir.
positive in clear cell. Yeah, it's negative in clear cell papillary. So,
Yes,
which
sir.
is again quite useful. RCC marker again, they tend to express only CK7. Okay. Any other? Do you know any other tumor which can have clear cell and papillary areas in the same tumor? So one of clear cell papillary, clear cell with papillary areas, and there is one more tumor which
Sir,
can again which can be
mighty
seen.
of translocation renal cell
MIT
carcinoma.
Yeah, well
family.
done. Yeah, very good. Well done. So I put this one now. Can you see this slide now? So this is clear cell papillary RCC. Okay. So you can have it usually it doesn't have well formed papillae. You should have very blunt papillae, compact tubular structures. Sometimes you can have this what they call the smooth muscle stroma, almost like a smooth muscle stroma within the tumor. A nuclei aligned at the apical end, which I mentioned before. So differential diagnosis is this. Sorry. It's clear cell papillary RCC solid variant, clear cell papillary RCC, and translocation carcinoma. That's also in the differential. So usually one other feature of translocation carcinoma, you should see samoma bodies, which will, if you see samoma bodies in clear cell and papillary architecture, think about translocation carcinoma. And usually they don't express cytokeratins very well. So the two tumors we have seen today, which don't express cytokeratin very well, is translocation carcinoma and SDH. They don't SDH as well. They don't express cytokeratin very well. So other markers, AMACAR, cathepsin D is quite useful in again translocation carcinomas, and the typical positivity is TFEB, TFE3 positivity. So I think the rest of the immunos you will be. I will try to share some of the all these this presentation with Padma Madam so that she can send it to you later, which will be might be useful. Okay, so this patient this is another patient had this clear cell papillary. So you can see it's again brown color, almost, if I don't tell you it's clear cell papillary, you will be thinking about oncocytoma or chromophobe kind of tumor. So that's the color, and you can see the tumor nicely located in the hilum. And they tend to be low grade. In this case, we saw grade 2 nucleus. Usually they'll be grade 1, and they don't, prognosis is good prognosis, clear cell papillary RCC. Yeah. Is it okay?
Yes, sir.
Okay, now we can go back to last case number.
That is Dr. Karthik, right?
Yes, ma'am.
Yeah.
Good evening, sir. This is the
Yeah.
last case, case number 8. The history
Yeah.
given was right upper pole lump, and what's the nature? So
Yeah.
the multiple section study shows 7 linear course of renal biopsy, in which 2 of the cores show renal cortex with 6 glomeruli, and other cores are taken from the tumor. The tumor
Okay.
shows diffuse sheets of plump cells with moderate amount of dense eosinophilic cytoplasm and mild pleomorphic hyperchromatic nuclei. Few of the nuclei show nuclear inclusions, and occasional multinucleated cells are seen. And many thick-walled hyalinized vessels are seen in between the tumor cells, and some of them having eccentrically placed lumen, and none of them showing elastic lamina. And the cells are crowded little around the vessels, and it appears to arise from the outer layer of the vessels. Very few scattered mature adipocytes are seen in between the tumor, and the
Yeah.
cortical portion of the adjacent kidney shows clusters of red blood cells in the proximal and distal convoluted tubules as well as in the glomeruli, but the
Okay.
architecture is preserved, and there is
Okay.
no areas of necrosis or increase in mitosis or areas of hemorrhage.
So with all these findings, my differential is epithelioid angiomyolipoma or oncocytoma like angiomyolipoma, sir.
Okay, very good. Yeah. So yeah, as you mentioned, we're not seeing much of adipose tissue. It's mainly spindle cells or epithelioid cells, and you can see this thick-walled blood vessels. Yeah. So what will you do for confirmation?
Sir, first, it is a benign mesenchymal tumor, sir. So the epithelial marker should be negative, and the positive markers are smooth muscle markers and melanocytic markers. So I want to do smooth muscle actin and any one of the melanocytic markers, HMB45 and Paxide, sir, to
Okay.
roll out
And what
these.
about, so what do you expected CAM 5 or cytokeratin?
It should be negative, sir.
Negative. Yeah. So that's yeah. Okay. And then that's CD10. You can nicely see it's positive in the normal, negative. CK7 is again negative. Yeah. SMA, smooth muscle actin, as you mentioned, it's nicely positive. HMB45, for my surprise, it was negative in this case. So that's why, as you mentioned rightly, you have to do better to do 2 melanoma markers. If you're suspecting strongly this is AML, better to do 2 markers. And that's what I did. And this is melanate with this red chromogen. You can nicely see it's nicely positive. So this is angiomyolipoma. Yeah. Yeah.
Yes, sir.
And then, as you mentioned, I think I don't have to add anything. This is a very common tumor, and many other things, because radiology is very good in identifying angiomyolipoma. So 9 out of 10 times they don't biopsy it because they are so confident. They say there is fat, and then we don't get biopsies. But rarely, when the tumor is fat deficient, then they're not able to differentiate between RCCs, and so that's when they biopsy it. So usually the difficult cases will get biopsied, and we need to have a high index of suspicion, um, because sometimes you can be mistaken for some other things. So so if you got epithelioid cells, then yeah, do a cytokeratin, and it will be quite useful. Cytokeratin, if it is negative, then you can other markers, melanie, HOV45. Cathepsin D is a very good marker for angiomyolipoma, so that's the other thing. So again, if you've got multiple angiomyolipomas, then we have to think about tuberous sclerosis. Benign has got a better prognosis. Yeah. So this is another cytokeratin negative renal tumor. So we have seen angiomyolipoma, SDH. What is the other one? This translocation mid-family translocation RCCs. So these are all negative tumors. So yeah, just a minute. So that's the end of my presentation. Can you, Padma ma'am, I'll be back in 1 second. Just
No
is
issues.
that
No
okay?
issues. Take your time. Take your time. Meanwhile, if there are any questions from the audience, you can type it. We will have a session with Dr. Karthik regarding the questions. You can unmute and talk, or
Padma
you
ma'am?
can. Yeah. You're audible.
Ma'am, this is Dhanlakshmi.
Yeah. Your voice itself, I'm able to hear you. You can come on video if you are okay.
Yeah, once Karthik is on the screen, I'll just say hi to Karthik, ma'am.
Yeah, definitely. You can come on video if you are okay with it.
Yeah, okay.
We should congratulate all the participants. All of them did a very good job regarding the description. It was really good. All the participants, like all the presenters, did a very good job in answering the questions also. So that was really wonderful.
Yeah, I'm back again. Sorry.
Yeah.
That's fine. Yeah. So
Yeah,
hope
Dr.
it was
Dhanlakshmi wanted to say
useful.
hi to you.
Hello.
Yeah, Dr. Dhanlakshmi, you can talk.
Hi, Karthik.
Hi, Dan. How are you?
Fine. It was really nice, Karthik. Really enjoyed all the slides. Really good cases.
Thank you. Hope
Thank
it
you.
was useful.
Thanks a lot.
Yeah, it was really useful. It was very methodical. Your approach to the cases And from the gross you started, and you told about all the important points and differentiating between the different variants with the gross picture itself, and you emphasized on the microscopic aspects of looking at the necrosis. Though it was very basic, it was really useful for practice. So you really concentrated on practical aspects mainly for PG. So it is going to be a very important and interesting session for the PGs mostly, and for practicing pathologists who are doing nephropathology and oncopathology. So you were emphasizing on the importance of renal sinus, renal vein, taking bits from those places. And all the cases were really interesting, and I think the presenters also did a very good job doing the
Yeah, they did.
description. So
I
that
think
was
yeah, they
really
did a very good job. I mean, I was trying to ask questions because sometimes if you ask questions, then you think, and
yeah. So you
so
were able to
yeah.
get the answers from them by asking multiple things.
No, yeah,
So
yeah,
that was really wonderful.
yeah. That's
So
okay. No problem.
it was an ultimate session. All of us enjoyed it thoroughly, and the sections were very nice. Like they were speaking to us by itself. So we really
Yeah, sure.
the sections were really good, and the link which you sent, we were able to see it.
Okay,
Initial links.
very good.
That
Yeah,
was
sure.
really good. So it was really a wonderful session, Dr. Karthik. We would
Thank you.
look forward for more and more sessions from you like this. So whenever you have time, so you can just
Yeah,
join.
will do. Yeah, I will try to do some. Yeah, definitely.
Yeah,
Sure.
that was really good. So we all enjoyed it.
Thank you.
Dr. Hema madam is there. She wants to talk something. Madam, you
Yeah,
can
yeah,
talk.
sure.
Hema ma'am,
You can hear me, Karthik?
Yes,
Oh,
ma'am.
yes,
Karthik,
definitely.
can
How are
you?
you? How are you, ma'am?
I'm fine. God bless you. I'm so happy
Oh,
to see you, Karthik. You did a wonderful job. Oh,
I
I'm
don't know.
so glad. No words
Whatever
to express my happiness.
whatever I learned from you, that I'm just trying to
No,
just
no,
build on
you
it.
have
That's
done a
all. I
great
mean, the
job. We have
foundation was.
learned so much, and today I have learned so many things from you, especially immunohistochemistry
No,
and the rare tumors. Karthik, I'm so glad. Thank you so
no,
much. Thank you.
no,
All
no,
the
no.
best. God
Thank you.
bless you and your family, your children, your
Oh,
wife,
thank you.
everyone.
Thank you.
Okay, da.
Thank
Thank
you,
you,
ma'am.
Pa.
Good
Thank
to
you.
hear from you actually after a long time.
Hello. Hello. Good evening, ma'am. This is Dr. Vinuta Malaichami, Karthik's
Hi. Hello.
college
We
mate.
both meet
Hi.
in Madurai
Yeah,
together.
yeah,
How are you?
yeah.
How are you?
It's so good to see you, Karthik.
Oh, it's
I'm
okay.
very happy, just a wonderful job from your side. And all my PGs also had done a very good job, and everybody. And you had highlighted us with all more pathology and how to approach a slide with the gross and gross எவ்வளோ முக்கியம் எல்லாமே சொல்லிட்டீங்க.
Yeah, definitely. I mean, I think some of the things we tend to think
Yeah, many
immunohistochemistry
people,
always gives the answer and
just
everything.
they go
It's
only
not
with the
the case.
slide.
No.
Yeah.
I think
That
more and more, I
point,
think,
I think
yeah.
it's very much clarified in your presentation. Hats off to
Yeah.
you, and do more
No, 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 no.
things like this, right?
Yeah, will
Nice
do. Yeah, I will
seeing
try
you.
to do. I mean, that's one of. I mean, I just wanted to share whatever I learned. I mean, many of these things.
That's there.
I mean, many of the things is just from experience, from practice. I picked it up. I don't want to, because all the other things we can get it from the books and journals and
Yes,
everything. But
yes.
that's what
The
I wanted to
experience,
concentrate.
what you
Yeah,
have learned, you had shared with us.
yeah,
You need
that's
a
the thing.
great mind for that, right? Many of them
Sure.
don't do that. That's why. And all your IHCs were very, very informative, and PGs will definitely know all these things, because what are the primary panel, everything you had dealt. You've done a very classical job. Thank you.
No, it's okay. Yeah, welcome. Good to
Hello.
hear from you, Vinita, after a long time.
Yeah, I'll talk to you.
Hello,
Yeah.
Hello, hi.
Hello, madam. How are you?
Karthik, how are you? I'm fine.
I'm fine.
Very nice.
Remember?
We had a very nice time.
Thank you. Yeah.
Listening to you for the last 2 hours.
Thank you.
The
Thank you,
time
ma'am.
போனதே தெரியல. And you have a very metamorphism மாதிரி உன்னை ஐடென்டிஃபை பண்ணவே முடியல. கம்ப்ளீட்டா மாறி போயிட்ட.
மாறிட்டேன். வயசாயிடுச்சு.
மாறி. Very nice to see you.
I still remember the Royapeta days when we tried to.
Yeah.
That was to be honest, that was the most interesting time in my career. Actually, that's when I interested in tumor pathology, and we were trying to do all the diagnosis, everything in the small lab, and I can't forget that time. Actually, it was a fantastic time at that time with maybe Shanti madam and yourself. It was a very good time.
Okay, God bless you
Thank
and
you.
wish you a happy 2021.
21. Yeah. Thank you, ma'am. Thank you.
Thank you, thank you.
Sure.
Nice
Dr.
to see
Karthik,
you.
this is a
Okay, bye.
small certificate which I'll be sending to you by mail.
Okay. Thank you.
Thank you. Thank you, Karthik, for this wonderful session. All of us really enjoyed, and that was a really good session. It's a boon for the PGs, I would say.
Yeah, that's great. Yeah. Yeah. Thank you.
So if there are any more, anybody want to talk to Dr. Karthik or anything like that? I didn't get your number, Karthik. I'll get it from you. Finally, I'll send a mail and
Yeah. Sure, you can get my number, and also if there is anything, if anybody wants to ask something, or you can they can send my email. You can give my email to them. They can,
I have actually sent your mail ID to some of them for career guidance mainly. Many of them wanted to know how
sure.
to. So I thought you will definitely help them out.
Sure. Yeah.
Those who really want to pursue further, because many of them want to come abroad. So if they are interested, you can just guide them how to go about and all that.
Yeah, definitely.
Yeah.
Yeah.
So if there are no more questions, I think we will end the session. Thank you very much for this wonderful
you're
lively
welcome.
session.
No problem. Okay.
It was
Thank
a
you.
very lively and interactive session. So all of them enjoyed it.
Very good. Yeah. Thank you, ma'am.
Thank you. Thank you.
Bye, Karthik.
Bye,
Hi,
Dance.
dear.
Take care.
Bye.
Hi to your family also.
Yeah. I don't know, for
Whenever
2
you
hours.
come.
I mean, they have been very quiet for last 2 hours. Otherwise,
I
they
can
won't
understand.
leave me like that.
Yeah. So whenever you come to Chennai, definitely meet us.
Yeah. I mean, that is definitely,
Yeah, after this COVID is over. Stay safe till then. Yeah.
That's why everybody is staying at home.
Yeah. Okay, Karthik.
Okay,
Thank
ma'am.
you.
Thank you, ma'am. Take care.
Thank
Yeah,
you.
bye.